this kind of CGM. Basically, this is the sensor that the patient wears, has to be changed every 5 days, and this is the monitor that shows, or the screen that shows the blood sugar, shows the trend arrows, and they can also set alarms and alerts for to be alarmed about the highs and lows. Calibration is necessary after insertion, and this type also has a built-in meter, so patient can also use it as a glucometer. This one has only been approved for use in the adult patients. Dexcom, very similar, has a sensor, and the screen sensor. This one has been can be worn for up to 7 days, and has almost the same features. And this one is also only been approved for the use in adults. So, our clinical guidelines from 2007, American Academy of Clinical Endocrinologists, they say that we should try to arrange for CGM for patients who have unstable glucose control or cannot achieve an target A1C, and in those who have nocturnal hypoglycemia, hypoglycemia unawareness, or postprandial hyperglycemia. So that's basically the idea. Now, since these devices have been approved, some, different patients, different clinicians have used them. So let's see really what's out there, what has been known from the clinical trials and the experience of clinicians. So this is a study of only 10 patients. Actually, this is from India, but was presented in ADA this year, and I found it quite interesting. These were 10 adult patients with actually good control. They were compliant patients with good glycemic control, and they wore the CGM for 3 days. And this particular clinical setting, they have like a remote device that they can kind of send their records directly to the clinician in the hospital, similar to what we have here with CareLink and the internet. And they can also, these patients could make adjustments in their insulin dose, as well as get instructions from their providers and make adjustments. And these are the results after only 3 days use of the CGM. So based on the information from the CGM, 50% of them make changes in the time of their meals, and about 70% made changes in the content of their food. Timing of the exercise and duration of the exercise, also they changed it based on the information that they got from this three day of CGM. About 70% recorded that they could sleep better, and 90%, so this is the best result, 90% of them said that they want to use it again. So this actually is, at least with my practice, this is better than a lot of results that we get here. But so it could be really helpful in real life. This is another study that in a actually university-based clinical practice in New York. They looked at they went back retrospectively and looked at 118 patients that were all pump users and also were using CGM. Some of the, the average age was 44, so, but there were some pediatric patients as well. 9 of these patients had actually type 2 diabetes. These patients used the CGM for at least on average 7 months, at least 3 months. And they looked at the severe hypoglycemic events, and with CGM, total 118 patients, 17 events of CGM of hypoglycemia, severe hypoglycemia was reported. These patients, again looking back, had 50 events prior to the use of CGM. So comparing these, obviously the p-value is very, very significant. So the occurrence rate dropped from 0.1 to 0.04. So obviously CGM can be very, very helpful in preventing the hypoglycemic, severe hypoglycemic events. And I believe from this total patient, 50% patient that had prior events, a good 50% of them had unawareness, hypoglycemia unawareness. So obviously this is very significant. These patients, their A1C, average A1C before, a year before use of CGM was 7.5, so we're good, kind of relatively good controlled patients, and with the use of CGM, their glucose dropped to the A1C dropped to 7.26. So comparing these two numbers, again, very significant statistically. And the best results was in the patients that used the CGM more often. So from the patients that had was wearing it more than 75% of the time, their A1C dropped actually from 7.4, average of 7.4 to 7.1, which is also clinically significant. Again, there is another analysis of the patients on clinical trials with CGM from the JDRF study. They wanted to find out what are the factors, which patients benefit the best from the CGM, and which patients are going to be adhering more to the use of CGM. So they looked at 230 patients from the multi-center JDRF study, and these patients, 165 of them had A1C of above 7, and 67 had A1C of below 7. The criteria for entering this study was age more than 8, so they had pediatric and adult patients. They were not in honeymoon, they were at least 1 year after diagnosis, but they had a cutoff for A1C, so the A1C had to be below 10. And all of these patients were on intensive insulin therapy, so either insulin pumps or multiple daily injections. So these patients wore the CGM for about 6 months, and then they kind of looked back and to find out which patients used the CGM more than 6 days a week at the end of the 6 months. So in other words, what are the patients that are going to be adhering more to the CGM. Now, they had divided the patients to 3 subgroups, based on the age. Age more than 25, between 14 and 25, and between 8 and 14. So adults had the best adherence, and age more than 25 was a factor that kind of they stayed with more than 6 days use the best. The worst group, what would you expect to be among these 3 groups? Yeah, 14 to 25 had the least adherence. And the patient that had, in their first month of CGM use, had used it more frequently, stayed with the CGM use better after 6 months. So kind of the first month, it's either they got better results because they were wearing it more often, and this kind of encouraged them and they stayed with the CGM better, or maybe they were patients that were more kind of aggressive, and they had more, they were paying more attention to their diabetes. But these 2 were the only 2, and the other factor was how often they were checking their blood sugar at baseline. So the ones that were checking more than 6 times a day, they stayed with CGM longer at the end of the 6 months. Then they looked at their glycemic control. So patients who in the first month of using CGM had better control and had more glucose levels within the range, they kind of used CGM more frequently by the end of the 6 months. So they stayed with CGM better. Also, patients who had less hyperglycemia during the first month, they also stayed better with the CGM. Again, this could be that the first month they used it, they saw good results, and they kind of kept going, or maybe this was kind of the selection bias. They were patients that were more diligent to begin with. Interestingly, the ones that had less hypoglycemic episode, it wasn't a significant factor in terms of staying with the CGM. Now, who got so this is how frequently they use the CGM. But who got the better results? So was it helpful? Did that make any difference in their A1C control? Again, you recall the patients were a group that had A1C of more than 7 at baseline, and the other group had less than 7. So in the patients with high A1C, the ones that had higher A1Cs at the beginning dropped their A1C more at the end of 6 months. So they got basically the best benefit. Now remember, these are patients that A1Cs between 7 and 10. But the higher, the better benefit. And obviously, the ones that used CGM more frequently had the best reduction in their A1C. So who used it the best? Adults, about 83% of them at the end of the 6 months still were wearing their CGM for 6 days. Kids younger than 14, about half of them. Teenagers, only a third. So, bottom line, not surprisingly, the ones that had were kind of more motivated or got better results in the first month, they kind of kept using the CGM for the whole 6 months of the study, and they got better reductions in their A1C. Now, how much the A1C changed? Again, for different age groups, when we look at the amount of the reduction in A1C, it's between 0.3 to maximum 0.5%. But again, these are the groups that the A1C was at the baseline between 7 and 10 only. They also looked at the psychosocial factors like hypoglycemia, fear, and a burden associated with diabetes, and they couldn't, based on the questionnaires that the patients had, there was no association with the adherence to treatment. But from this authors, they mentioned that one factor that was not kind of studied, was not asked from the patient, was the expectations from the CGM. So maybe if we look at the expectation at the beginning, we will kind of find it significant in terms of the staying with the treatment. Now, the ones that had good A1C, so at the baseline, they had A1C of less than 7. Did they get any benefit from the CGM? Do we have any reason to recommend it to the patients or not? Well, this group, they had a reduction more than 0.3%, but they had less severe hypoglycemia. So the control group had about 28% hypoglycemia. The patients that had CGM only had 5%. And also at the end of the 6 months, there were more patients in the CGM group that had still had a target A1C, versus in the control group there were more patients that had the A1C had kind of gone out of the control range. Again, breaking into by age